Imagine a severe liver condition, one that's rapidly fatal. And for decades, life-saving surgery was just, well, it was off the table, a medical never.
Completely off the table.
But now we're seeing this profound shift. It's moving towards sometimes, and it's actually saving lives. How do we get here? From that absolute never to, well, sometimes, and it works.
It's a fascinating journey.
Today we're doing a deep dive into exactly that. Acute alcoholic hepatitis, or AAH, and the really evolving role of liver transplantation.
Yeah, our mission today is to sort of unpack the research, the big studies that have come out. We want to help you understand the huge medical changes, the ethical tangles, which are significant.
Oh, definitely.
And the pretty remarkable outcomes when using liver transplantation for a very, very specific group of patients with AAH. We're here to distill the key takeaways for you.
Okay, so let's start right at the beginning. What exactly is acute alcoholic hepatitis?
AA, right. So AAH at its core is this severe inflammatory injury to the liver. It hits people with a history of chronic, heavy alcohol use, and the scary part is how fast it comes on.
Rapid onset.
Very rapid. You see jaundice, the liver starts failing, and tragically, the short-term mortality rates are, well, they're very high.
And historically, that high risk, plus the alcohol connection, created a huge barrier for transplant, didn't it? What was the thinking?
Well, yeah, traditionally, AAH was seen as an absolute no-go for liver transplantation, an absolute contraindication.
Why was that?
There were major ethical concerns. I mean, primarily, the fear was about relapse, right? Someone gets this incredibly scarce organ and then starts drinking heavily again.
Wasting the organ, essentially.
That was the fear. And also questions of fairness. How do you allocate an organ to someone whose illness is linked to alcohol when you have others waiting, sometimes for years with different conditions? It was a real sticking point.
Okay, here's where I think it gets really interesting, biologically speaking. The damage mechanism in AAH. It's not just straightforward alcohol toxicity, is it? What makes it so uniquely destructive?
That's a critical point. It really is a perfect storm inside the liver. So chronic heavy drinking actually makes the liver cells more sensitive to injury. It primes them, if you will. Then an acute binge, more heavy drinking, acts like a trigger, and this sets off a whole cascade. First, your gut bacteria get thrown out of balance. That's called gut dysbiosis.
Right.
This leads to bacterial toxins like endotoxin or LPS leaking into the bloodstream and reaching the liver. These toxins then activate these specialized immune cells in the liver called Kupffer cells.
And they sound the alarm.
They sound the alarm, but it's like the alarm goes haywire. They start churning out massive amounts of pro-inflammatory chemical cytokines. Think TNF-alpha, IL-6, IL-8. It's an uncontrolled inflammatory explosion. And that, combined with oxidative stress, damage to the mitochondria, the cell's powerhouses, leads to widespread liver cell death. And crucially, the liver's own ability to repair itself, to regenerate, is also severely damaged in AAH. So it just can't keep up.
So it's this vicious cycle: inflammation, cell death, and impaired repair. That paints a grim picture. How severe are we talking mortality-wise if treatment doesn't work?
Extremely severe. I mean, for the cases we identify using specific scoring systems like a discriminant function or MDF score of 32 or more, or a MELD score of 20 plus, or an ABC score over 9.
These are ways doctors measure how bad it is.
Exactly. They quantify the severity and predict risk. For patients hitting those scores, the 28 to 90-day mortality can be 30 to 50%, sometimes even higher, especially if they don't respond to the initial therapy.
Okay, so given that immediate danger, what's the standard medical approach? What are the first things you have to do?
The absolute non-negotiables are, first, stopping alcohol completely. This often needs careful medical management for withdrawal symptoms.
Critical first step.
Absolutely. And second, aggressive nutritional support. Almost everyone with severe AAH is severely malnourished. Protein-calorie malnutrition is universal. You have to tackle that aggressively.
And then what about medications? Is there a go-to drug treatment?
Yes. The primary first-line drug treatment for severe AAH is corticosteroids. Prednisolone is the common one.
And how do they help?
They work by trying to dampen down that massive inflammatory response we talked about, trying to calm that cytokine storm.
Okay, but how do you know if the steroids are actually, doing their job? Is there a way to check?
Yes, and this is crucial. There's a tool called the Lille score. It's calculated after the patient has been on steroids for 7 days.
And what does it tell you?
It's vital for predicting who isn't responding to the steroids. A Lille score greater than A045 is a strong predictor of non-response, and unfortunately that signals a continued very high risk of death.
Which brings us right to the major limitation here, doesn't it? The steroids don't work for everyone.
Exactly. That's the crux of the problem. Only about, say, 50 to 60% of patients actually respond adequately to corticosteroids.
So 40 to 50% don't.
Right. And for those non-responders, the ones with that high Lille score, the prognosis is just dismal. We're talking over 70% mortality within 6 months. And here's the kicker. There's no widely accepted effective second-line medical therapy for these patients.
So they fail steroids, and then what? There's nothing else proven to work.
Medically, not really, not reliably. They're essentially facing imminent death with very few options left.
That paints a really stark picture. So what happens then? When the standard stuff fails, the patient is staring death in the face.
Right.
What does the medical community do? That's a huge ethical and medical challenge.
It absolutely is. And that profound short-term mortality, over 75% at 6 months for those steroid non-responders, combined with that lack of other effective medical options, it really forced a reconsideration.
The argument for transplant became stronger.
It became compelling, urgent even. The primary goal shifted towards simply saving the lives of these individuals who, frankly, had no other realistic path forward.
Which leads us right into the landmark study, the one that really shook things up and challenged decades of thinking. Mathurin et al., published in the New England Journal of Medicine back in 2011.
That study was absolutely pivotal, groundbreaking. They looked at 26 highly selected patients with severe AAH who hadn't responded to steroids.
So the Lille 0.45 group.
Precisely. The ones with that grim prognosis, life expectancy under 6 months. And these selected patients received an early liver transplant. Early, meaning a median of just 13 days after they were identified as steroid non-responders.
13 days. That's incredibly fast in the transplant world.
Yeah.
And the findings, what did they show?
The findings were stunning, really. The 6-month survival rate for the patients who got the early transplant was 77%.
77%.
Yeah.
Compared to what for similar patients who didn't get a transplant?
Compared to just 23% in a carefully matched control group. A massive difference. And it wasn't just short-term. The 2-year survival was also way higher, 71% versus 23%.
Incredible survival benefit. What about the relapse concern? The reason this was always considered a no.
That was perhaps the most surprising finding for many. The alcohol relapse rates were actually quite low. Only 3 out of the 26 patients, that's about 11.5%, had returned to drinking by the median follow-up time of around 25 months.
Much lower than many might have feared.
Much lower. And this study, with those dramatic results, it essentially proved the concept. It showed that early transplant was feasible, offered a huge survival benefit, and could be done with manageable relapse rates if patients were selected carefully. It truly paved the way for a paradigm shift.
And subsequent research has backed this up generally.
Yes, broadly speaking. Many other centers and studies have replicated these findings. They consistently show high short-term survival after transplant for AH, often 80-95% at 6 months, and pretty good long-term survival too, like 70-85% at 5 years.
Comparable to transplants for other reasons.
Very comparable, yes. And the relapse rates, while they vary a bit between studies, generally fall in the 10-30% range at 5 years, which again is quite similar to what we see in patients transplanted for the more traditional indication of alcohol-related cirrhosis after a period of sobriety.
Okay, so the outcomes look good, but you mentioned highly selected patients earlier. That sounds critical. Who actually qualifies? It can't be just anyone with AAH who fails steroids, right?
Absolutely not, and this is paramount. Because of the ethical complexities and the simple fact that donor organs are scarce, the selection criteria have to be incredibly strict.
Right. So walk us through those core principles. What makes someone eligible?
Okay, first, you need a definitive diagnosis of severe AAH. That means meeting those criteria we mentioned, like MDF-32 or MELODIA-20, and they should have qualified for steroid treatment in the first place.
Makes sense. Step 1.
Step 2. Documented failure of that medical therapy. That Lille score, 0.45 after 7 days of steroids, is key, confirming they're in that higher-risk, non-responder group. Third, and this is important, they generally shouldn't have had previous episodes of liver failure complications before this current AAH episode. So no prior history of ascites or variceal bleeding or hepatic encephalopathy. This is typically their first major liver decompensation.
Okay. So it's really targeting that acute first-time severe event.
Exactly. And finally, they need to be otherwise reasonably healthy, meaning no severe, uncontrolled other problems like active sepsis, really bad heart or lung disease, or cancer elsewhere in the body that would make a major surgery like transplant too risky or futile.
Got it. That covers the medical side. But Given the alcohol context, what about the psychosocial aspect? You hinted that's huge.
It's arguably the cornerstone of the selection process. It's a really rigorous psychosocial evaluation, not just a quick checkbox exercise.
Who does that?
It's a multidisciplinary team effort, usually involves addiction specialists, psychiatrists, social workers, the whole team.
And what are they looking for?
Several key things. Does the patient truly understand that alcohol caused this devastating illness? Do they have insight?
Crucial.
Absolutely. Then, is there a demonstrated commitment to staying sober? Not just saying it, but is there a credible plan? Do they have strong, stable social support family, friends who can help them?
That support network must be vital.
Incredibly important. They also look for the absence of other severe psychiatric problems or active abuse of other substances. And critically, is the patient willing to engage in long-term addiction treatment both before and definitely after the transplant?
Okay, now this brings us to what feels like the most contentious part. The traditional 6-month sobriety rule. You're saying that's waived in these protocols. How does that work without being hugely controversial?
It is hugely controversial. There's no way around that. That 6-month rule has been standard practice for alcohol-related liver disease for a long time.
So what's the justification for dropping it here?
Well, the justification comes down to the severity and acuity of AAH in non-responders. They don't have 6 months. They'll likely be dead long before then if they don't get a transplant.
So it's a time issue.
It's a time and mortality issue. So while the duration is waived, the commitment isn't. Documented abstinence while they're in the hospital during the evaluation is essential. The emphasis shifts from an arbitrary waiting period to a deep assessment of their insight, motivation, and support system right now via that intensive psychosocial evaluation.
But the debate still rages, I imagine.
Oh, absolutely. Critics raise very valid points. Does it undermine fairness for other patients on the list who have achieved sobriety and waited? Does it increase the risk of relapse because there hasn't been that test of time? Could it even discourage some people from trying to get sober first if they think transplant is an immediate option? These are serious concerns.
And the proponents, what's their core argument?
Their core argument is stark. Denying a transplant to these selected steroid-nonresponsive patients is effectively a death sentence. They argue that the rigorous psychosocial screening is the best tool we have to mitigate relapse risk in this urgent situation, and the survival data supports this approach.
Then there's the allocation dilemma itself. These AAH patients are often quite sick, high MELD scores, meaning they jump up the wait list. How do transplant programs handle prioritizing them over others who might have been waiting longer?
That's another huge ethical challenge. It touches on principles of utility, maximizing benefit, and justice, fairness, and distribution. Most programs that do these transplants have very specific protocols. They prioritize based on medical urgency, yes, but only within that strictly defined group who meet all the selection criteria, including the psychosocial ones. It's not opening the floodgates.
And predicting relapse.
Yeah.
You said the tools aren't perfect. That must be an ongoing worry.
It is. We can assess risk factors, insight, support, but we can't guarantee future behavior. There's always a concern about the transplanted liver being damaged by recurrent drinking, although, as we said, the data so far suggests that severe graft damage due to relapse isn't as common as feared and seems comparable to traditional alcohol-related transplants.
What about public perception? Does that play a role? The idea of giving a scarce organ to someone with a perceived self-inflicted illness without that waiting period.
It definitely does. Maintaining public trust in the fairness and integrity of the organ allocation system is vital. Transplant centers are very aware of this, which is another reason why the selection process is so stringent and transparently protocol-driven. It's a complex balancing act.
So assuming a patient successfully navigates this complex selection and gets the transplant, what does life look like afterwards? Obviously, immunosuppression drugs are standard, but what else is critical for this specific group?
Beyond the standard post-transplant care, the absolute linchpin for long-term success here is ongoing addiction management. It's non-negotiable and just as important as taking their anti-rejection meds.
What does that look like in practice?
It's usually quite structured. Mandatory participation in addiction treatment programs that could be regular counseling, support groups like AA or Smart Recovery, whatever fits the patient,
Right.
and close, regular monitoring by addiction specialists. They might also consider medications specifically for alcohol use disorder, things like naltrexone or acamprosate, to help maintain sobriety.
And screening for alcohol use, how is that done?
Regularly, it involves self-reporting, of course, but also objective measures, using biomarkers in the blood like PEth, ETG, CDT. These are more sensitive tests that can pick up recent alcohol consumption. And sometimes breathalyzer tests, too. It's about having multiple ways to track progress and catch any slips early.
What if someone does slip up? Relapse happens in addiction recovery. Does that mean they automatically lose the graft or get kicked out of the program?
No, not automatically.
Wait,
The key is early identification and intervention. A slip or relapse triggers intensified support from the addiction team. The goal is always to help the patient get back into recovery. It doesn't necessarily mean the transplant has failed, especially if caught early.
okay. And despite all these challenges, the selection, the ethics, the relapse risk, you mentioned the outcomes, are generally excellent.
They really are, remarkably so. Patient survival rates, as we said, are high 80 to 95% at 6 months, 70 to 85% still alive at 5 years. That's right up there with survival rates for transplants done for other liver diseases. Graft survival, the transplanted liver working well, is also generally very good.
And refining the relapse picture a bit more, you gave a range earlier.
Right. The overall relapse rate, meaning any return to drinking, is somewhere in that 10–30% range at 5 years, based on various studies. But importantly, harmful relapse, the kind that significantly impacts their health or the new liver, seems to be lower, maybe in the 10–20% range at 5 years.
Are there factors that predict who is more likely to relapse?
Yes, some risk factors have emerged. Things like weaker social support, maybe less insight into their addiction before the transplant, and having other significant psychiatric conditions seem to increase the risk. But it's important to note that actually getting severe AAH again in the transplanted liver is extremely rare.
Okay, so let's try and wrap this up. We've covered a lot of ground on this deep dive. It feels like liver transplantation has genuinely carved out a new vital role for a very specific subset of patients with severe AAH.
I think that's exactly right. It's emerged as a truly life-saving therapy for this highly selected group, those with severe AAH, who fail medical management and face near certain death without it.
And the key seems to be that combination, the dire prognosis without transplant, coupled with incredibly careful selection.
Precisely. The work by Mathurin and all the studies since really show these remarkable survival benefits are achievable with early LT, but only when paired with that rigorous multidisciplinary selection process that heavily emphasizes psychosocial stability, insight, and a solid commitment to abstinence, even if the traditional 6-month rule isn't met. That was the real leap.
And it's still evolving, right? The ethical debates aren't settled. The processes are likely still being refined.
Definitely. Significant ethical questions around organ allocation and relapse risk absolutely persist. But the accumulating data does seem to support the careful, protocol-driven use of early liver transplant for the specific indication in centers equipped to provide the necessary multidisciplinary support.
What's next? Where is the research focus now?
Well, ongoing work is looking at further refining those selection criteria. Can we get even better at identifying the best candidates? Also, optimizing the long-term addiction management strategies, and importantly, still searching for better medical therapies for AAH, so maybe fewer people reach the point of needing a transplant in the first place.
It's an incredible story of medical advancement meeting a desperate need. So the final thought I want to leave our listeners with is this. Given the profound impact here offering life where death was almost certain, what does this whole evolution tell us about how we view disease, addiction, and maybe even who we consider deserving of the most advanced life-saving interventions?
That's a powerful question.
It really challenges us, doesn't it, to balance compassion, the latest science, finite resources, and deeply held societal values. It's a conversation that's clearly far from over.